Good evening. Can everybody hear me okay? Great. You know, we'll go ahead and get started right on time. I'm Mark Williams. I'm very pleased to be your program chair this year and start us off talking about a very popular subject these days. Before I get going, I want to give you some housekeeping announcements. There's a lot of information in your black binder. Make sure you look through that black binder with instructions on how to get CME credit for these presentations. The presentations are on your flash drive, but as you'll see tonight, mine have been somewhat updated. That'll be available through the website, so whatever you see here will be available. You don't have to worry about taking notes if of course, you find any value in it. Tonight, we had scheduled a reception out on the lawn, but because of the weather, we're going to have it in the lobby here. And it'll be a lot of fun, so I hope everybody stays around for that. Across the hallway here, this year we started a tradition that we had going in the past we hadn't done last year, and that was a lot of the poster presentations. So the hospitality room, the continental breakfast, the posters are all across the hallway. So during the next day and a half, please take time to visit those areas. And then the awards lunch and tickets for Saturday afternoon are still available up at the, and you can purchase those up at the registration desk. So hope you all take advantage of all those things. The talk tonight will last about an hour and 20 minutes, and we'll give time for question and answers afterwards. And my purpose here, I think there's some Florida CME requirements, but my purpose in this presentation this evening is not to tell you all about medical errors and safety and high reliability. It's to introduce you to many of the broad aspects of patient safety now. To give you a little background of what I do, I'm an anesthesiologist. I work about 10 or 15% of the time as an anesthesiologist. I'm the chief medical officer of a large Mississippi system, and we have 7 hospitals, 30-some-odd clinics, 6,000 employees. So medical errors and events, one way or the other, cycle through my office. So that's my view of the world, is I often see these every day. And that'll probably be reflected in my presentation. So I take these things very seriously. But when we talk about safety and medical errors, at the end of the day, that is the foremost opportunity for physician leadership that I see for doctors today, is because they can be real role models in patient safety and can truly make a difference. So with that, we'll get going. The objectives today is, what is a medical error? Where are we in the whole safety movement in the U.S. healthcare? What is culture? Specifically, what is culture? What is the culture of safety? What is a just culture? We'll talk about all those things. And then I want to introduce you to the concept of a high reliability organization. We'll come back to this diagram at the end of the talk. I just want you to take a careful look at these things. I'm not going to say anything about it now, but we'll come back and discuss it because each one of these things has a little story behind it. People often intermix the terms quality and safety, and the way I describe it to people is, if you come into the hospital to have a gallbladder, an elective gallbladder operation, the quality is, I want a clean incision, I don't want to have nausea and vomiting, I want to have minimal pain, I want to have a good experience. That's the quality piece. The safety piece is, while you're doing these things, don't burn me, don't drop me off the OR table, don't give me the wrong blood infusion, don't let me fall when I'm in the post-operative period. That's the safety piece. So when you think of quality, think of applying best practices, and when you think of safety, think of avoiding harm. And this is what we live by at North Mississippi Health System: right care, right time, every time, without harm. There's a new little parenthetical phrase underneath that says, at the lowest cost. That's the value piece. You'll hear, in any safety discussion in healthcare, you'll hear of several institutions, just so you know what they are. You'll hear about the Institute of Medicine, and for some of you all, you may have heard that 2 weeks ago, they released a big paper on the state of oncology care in the United States and how fragmented it was. That document has now become a reference document for almost every cancer center in the United States in terms of what is the vision of a great cancer center. But visit their site, a lot of information there. You'll hear about the Institute for Healthcare Improvement, the IHI. Last year, the IHI had 18,000 attendees at its meetings, to give you some idea of the interest in the patient safety movement. The Joint Commission. People joke about the Joint Commission. In my world, they joke about a new Joint Commission rule. Recall that the Joint Commission was formed by the American College of Surgeons to assure hospital safety. So whatever we say about the Joint Commission, let's attribute it to the surgeons. How do we compare to other countries on this notion of quality and safety? And many people will agree or disagree with some of these perspectives. But this is from the Commonwealth Fund. This is actually several years ago. Commonwealth Fund, a very large philanthropic fund in New York. It's regarded as sort of the world's foremost authority on comparing healthcare systems. And when you look at quality care, which in this one, quality care encompasses safety, among these 6 countries, as you can see, the U.S. came in 5th, and they happen to come in 5th at a cost roughly twice anybody else. If you look at a more recent comparison, when they added the Netherlands, many people figure the Netherlands has a healthcare system closer to ours than any of the other 5. They've actually broken out safety in this one, safe care. And so of those 7 countries, again, the U.S. shows up as number 7 in safe care. Y'all believe that? Yeah. Okay, yeah, there's a yeah. But let's go through this and see where you're left at the end of the talk. Now let's break it down to states. Now this is the Southern Medical Association, so I got a few southern states there. I got the 2 states where I work in, Alabama and Mississippi. And again, quality care and avoidable hospital costs. Many hospital costs arise because of medical errors. So when you talk about avoidable hospital costs, often you're talking about costs associated with something that didn't go well. And again, where is Mississippi? 44, 49. Alabama fares a little better. Tennessee a little better. But that gives you some idea of the relative of where we stand in some of these places. Who's interested in quality and safety? These are just a few of the organizations that have banded together to focus on patient safety. And they are no small organizations. They're the National Business Group on Health. Many of you all heard Helen Darling when she came to Nashville last year. You saw her emphasis on hospital quality and safety. U.S. Chamber of Commerce, American Nurses Association, the AFL-CIO, a whole range of people. This is one of their 6 priorities, safety. So I'm going to tell several stories during this presentation. Some of you from North Mississippi have heard some of my stories. I think we may have even heard them at some SMA meetings. So I'm in Tupelo, Mississippi in March 2010 at the Books A Million, and I hang out at bookstores a lot. And I'm looking at the newest consumer reports, and I'm into electronics. I'm drawn to this issue because of TVs, But there's a thing at the top right there that says hospital germs, hidden dangers. Now, what is Consumer Report doing talking about hospital germs? So I'll go to the article, and while I'm looking at this article, there's a brand new book that's on a special stand right next to it by Peter Pronovost, who's an anesthesiologist from Hopkins, who's one of the world's foremost safety experts. So I'm looking at both these books. I open up this magazine, and there's this incredibly detailed article on central lines, the placement of central lines. It gives the anatomy of a central line. This is in Consumer Report. This is not in the medical book. And then it talks about someone whose loved one died from a bloodstream infection acquired from a central line. Talks about the associated average cost of an infection associated with the placement of a central line, $42,000. Flip another page, and coming clean on hospital infections. Here we're actually reporting how different institutions do. And I know you can't read this, so I pulled out a few. Now I'm in Tupelo, and we send patients to to Memphis and to Birmingham and to Jackson. And I'm thinking, well, I know Mississippi's not in there because there are no infection reporting laws in Mississippi. But most states have them, and almost all states will soon have them. But Tennessee has one. So I say, well, let's see, if we send patients up to Tennessee, some of our patients go to what we call the MED, Regional Medical Center at Memphis. So if you were the administrator, the administrator of the med, the morning after this consumer report came out, and it showed 238% more infections than average, how would you respond when the newspaper reporter called you as soon as the office was open? So I went back and I said, well, how did they respond? Well, this is from the newspaper that day in Memphis. The med, local hospitals increased efforts to battle the blood bugs that kill. The med and Methodist continue to be tagged as significantly higher, but both hospitals working harder. When those numbers came out, that was our first opportunity to see what other hospitals were able to do. Sunshine, meaning transparency, is a great disinfectant. So a lot of lessons here. Maybe they never knew their rate was that high. Maybe the hospital next door had a best practice that prevented these, but no one ever bothered to share them. Those are the lessons that can come out of this. Now, what about Obamacare, the Patient Protection Affordable Care Act? What does it say about safety? You know, it has, as you know, a whole lot's in that bill, but it does say continued focus on quality, efficiency, and safety. Now, the continued focus is a focus that was already underway by Medicare. So Medicare already says we're going to penalize you for excessive readmissions. We're going to penalize you for poor patient satisfaction and poor outcomes and poor processes of care. And the third bucket that's coming up, we're going to penalize you for hospital-acquired conditions, or what we would call avoidable harm. What's the big deal? Well, if you add all those up, on the admissions piece, that's 3%. Value-based purchasing is 2%. Hospital-acquired conditions is 1%. That doesn't affect that single episode of care. That potential 6% applies to your entire Medicare revenue for the year. So you can see that these sort of things get the attention of hospital administrators for both patient quality and safety issues. And if you don't do it right, you're going to lose your bottom line and put your organization at financial risk. If you're in Alabama, and you know that in 2010, Alabama started tiering hospitals in Alabama. And if you look now at the insurance exchange, the co-pays differ between which hospital you choose to go to. So a big piece of that scoring system for Blue Cross was patient safety. In fact, patient safety had a total of 30 out of 100 points. Now, you can agree or disagree with the philosophy and the approach, but it matters to people. It matters to payers. We recall that we talked about big employers last year, Helen Darling. Well, I used to work for Alabama Power briefly as a medical director, and they hired a company called Best Doctors because they were very concerned about diagnostic errors among their employees. As you know, as many as 30% of cancer diagnoses are wrong. That's why Peter Pronovost, the world's foremost patient safety expert, even went into this area, because his father had a misdiagnosis between leukemia and lymphoma and died early from an inappropriate treatment. Well, not only did Alabama Power do something like that, they began putting out their own newsletter on patient safety and misdiagnoses. They launched their own website. They hired nurse practitioners to man that website 24/7 because it mattered to their employees and it mattered to their bottom line. So exactly how often does this happen? Who remembers this in 1999 when this came out? Do you remember the responses when they said 98,000 people died each year? They said, there is no way. That was more than automobile accidents. That was more than breast cancer. It was just no way. You people outside of healthcare don't know what you're talking about. In large measure, it was dismissed. Well, a more recent study. Yeah, the 98,000 was probably off, all right. It's probably double that, just among Medicare beneficiaries. Well, if you go through just recent claims data, just a few months ago, 1 in 7 Medicare patients harmed during a hospital stay. So how do you hear about these stories? You know, do you read the statistics about your hospital? Oops, they're not available, right? No one knows how their hospital performs. In fact, no one knows how your surgeon performs. Any of you had elective operation, ever ask your surgeon what his infection rate is? Would you get an answer? If you got an answer, do you think it'd be accurate? And I'm not saying anybody's wrong or anybody's trying to mislead. It's just the information's not there. We remember these stories because of people, because of headlines. Libby Zion, who remembers that name? Betsy Lehman, Willie King, Josie King, Jessica Santillan, the Quaid newborns. What about these people? Well, Libby, 18-year-old, misdiagnosed with dehydration and depression, died because the New York courts claimed a resident had been working 80 hours, had 40 patients, and the attendings wouldn't respond. It was the launch of the entire change in our restriction in residency work hours. We have Jessica Santillan, a very young 17-year-old treated at one of the finest hospitals in the country with a heart-lung transplant, and whoops, they gave the wrong set of heart and lungs. It wasn't compatible. What about Willie King, notorious? The surgeon said, oops, I amputated the wrong leg because the nurse had the wrong one draped out. Josie King, an 18-month-old, falls in her parents' tub into scalding water. She survives the burns. Johns Hopkins treats her burns. Her burns are fine, and they kill her from a morphine overdose. The Quaid newborn, Betsy Lehman, the reporter treated at a world-famous Dana-Farber Cancer Institute, gets a mega overdose of cancer chemotherapy. The Quaid newborns, two twins born shortly after birth, they get 1,000 times overdose of heparin just to clear a line. That's how we know about these things. The thing is that these things are happening in your hospital or where you work every day. So a newer study that came out, 210,000. So whatever study you read, there's something there. There's an opportunity. So what exactly is safety, and how do you measure it if you can't know the infection rate that your surgeon has or whoever? Well, this is our main hospital. This particular hospital safety score, which came out about 9 months ago, it got a lot of national press. We think we're a pretty hot hospital. We have a bunch of things on our website that have National Baldrige Awards as highest performing hospital in the United States, which that is important. But we only get a B when it comes to patient safety. But B was the highest grade that any Mississippi hospital got. In fact, it was the highest grade that any Alabama hospital got. And what goes into this particular safety score was a lot of different things. The SCIP measures, which are the surgical care improvement project measures, patient safety indicators, a lot of different things. And again, people will honestly debate how we determine these things. What really brought this to the insurance company's attention was back in Pennsylvania in the late 1990s. Insurance companies started noticing patterns. And they say, man, alive, the average hospitalization in Pennsylvania costs us about $7,000. But when we get a surgical site infection or urinary tract infection, pneumonia or bloodstream or whatever, and these are actual monies paid by commercial payers. This is not claims charge data. This is not Medicare. This is commercial payers. It was like, wow, a bloodstream infection, $75,000. Now, of course, none of us want to be these patients, right? But there's perverse incentives in healthcare, right? At that time, if that hospital accidentally, unintentionally, while trying to provide great care, did give that patient a bloodstream infection, wow, there's a financial windfall. That hospital would get paid $75,000. There was no disincentive, really, to keep these things from happening, no matter how hard the providers worked to prevent these things. There's no blame here. It's the way our system's been set up. So if you look in Medicare and you say, okay, what are these avoidable injuries that happen each year to all of our Medicare providers? The number one is pressure ulcers. So 400,000 Medicare beneficiaries each year get a pressure ulcer. And as you can see, the green and the blue is thought, due to error, just put avoidable there. Probably avoidable is the blue piece. And you can go down the list here. And many people in our main hospital thought you couldn't avoid certain pressure ulcers. Well, we'll tell you can avoid all pressure ulcers. And I'll show you some of that later. Before I worked in Mississippi, I worked as the chief medical officer for the St. Vincent system in Birmingham. Birmingham is part of Ascension Health. Ascension Health is the largest Catholic system in the United States. It's the largest private hospital system in the United States. Well, they had some extraordinary leadership back then, at 2003, that said, you know, we believe all avoidable harm is preventable. And we are going to settle for nothing less than eliminating all avoidable harm. And that's a very difficult thing to explain to doctors or to anybody, that we can eliminate all of it. So in 2005, they set the goal of no preventable injuries or deaths by July 2008. How did they do? Well, while I was working for St. Vincent's is also when I went to work briefly for Alabama Power. And I would share this St. Vincent's initiative with the CEO at Alabama Power. And I would talk about this goal of zero and how hard it was to reach and explain. And he would look at me like I was something out of outer space. He says, what do you mean you can't pursue zero? Mark, look what we do. We pursue zero every day. We have a hand hygiene program at Alabama Power. We can't get it into a hospital, but we can get it at Alabama Power. We tell our employees every day how many injuries occurred. He said, Mark, what if you came to the Alabama Power website and you looked at our safety initiative and we didn't have zero, but we said we were okay with frying 2 linemen each year. He said, who would buy that? So why can you make the argument that that's okay in healthcare and it wouldn't be acceptable in any other industry? Very hard to counter that. So when we talk about healthcare encounters, let's get back to the definition of medical errors and the categories. We know that some encounters have errors. We know that some errors never affect a patient, and we call those near misses. And those are great learning opportunities because there's no medical liability issue. There's no reason to keep it secret. So at the very least, an organization needs to champion and share things that almost happened. And then there's the ones that result in harm. Some of those are non-preventable. We're not talking about we're going to erase all complications and harm that happens in hospital. We know some of them are not preventable. But some of them are preventable. And in some of them, it's poor training. And in a very small section of it, sometimes it's just downright negligence. But that's kind of a scheme of how we would categorize errors and where all these things fit. So we have a near-miss safety event that does not reach a patient. We have a precursor safety event that reaches a patient but results in minimal harm or no detectable harm. And then we have what we call the serious safety event. And there are actually schemes that measure the type of harm. So when I get an incident report or a harm event reported to me, and it goes to what we call our good catch committee, and they say, okay, where does it fit in here? Temporary harm to patient, intervention required, or maybe it required more hospitalization. Maybe the patient died from it. We keep track of all these things, just like all hospitals should. Well, how do you find out about these things? Do you rely on a nurse or a doctor to say, there was an event of harm, and I was told by administration to fill out an incident report, and here it is. How often do you think someone will bother to fill out an incident report? Sometimes they will, sometimes they don't. We can get a little more sophisticated and look at our claims or billing data for these events that might happen, that when we looked at an unexpected post-op respiratory failure, we work backwards and find something that didn't work well or work right, an error. So if you look up here with incident reports, you're not going to find as many opportunities as you will with using a better analysis. So what are these events that happen in hospitals that get so much of the public's attention? Well, you know, when events are serious, we call those serious safety events, we call those sentinel events, because hospitals should wake up and pay attention to what's happened. And the Joint Commission asks that you voluntarily report these to the Joint Commission. Many hospitals, their attorneys or legal counsel would say, don't ever report it. Other hospitals will say, you report it every time. It's all over the map. It's not required. To give you an idea, when New York State required that all hospitals report sentinel events, in 1 year there were more sentinel events reported in New York than there were in the other 49 states put together. These are the type of things that happen in hospitals. It's estimated that fewer than 2% of sentinel events are reported. So are we moving forward or backward when it comes to patient safety? There's all kinds of opportunities. But one tool that's really come out from the IHI that says this is a great way to find an error is called the Global Trigger Tool. So I'm an anesthesiologist, and I got somebody reviewing the charts, and they show that my patient was reintubated. Somebody looking at the chart says, Dr. Williams' patient was reintubated in the recovery room. Now, I didn't write an incident report on having to reintubate somebody in the recovery room. It wasn't necessarily picked up on claims data, but they're saying, with the Global Trigger Tool, I got a trigger. Patient was reintubated. Let's ask why. Was it because Dr. Williams inadvertently picked up the wrong neuromuscular blocking agent? Was it because Dr. Williams gave the wrong or inadequate dose of reversal agent? Was it because Dr. Williams failed to properly treat a patient with myasthenia? But you can see, depending on how sophisticated we want to be in our analysis, it's going to determine what opportunities we find. So trigger tools brought to you by the IHI. These are just some of the examples of trigger tools. And again, I'm just trying to give you some insights as to these different tools that are available. Who's heard of the Swiss cheese effect? Anybody? You know, the Swiss cheese model means that, it simply says that we know errors are going to happen in healthcare. We know humans are going to make mistakes. And our goal should not be to keep humans from making mistakes, because we'll be eternally frustrated. What we should do is design a series of protections, sort of that Swiss cheese effect, so that the holes never line up to allow a mistake or an error to harm a patient. And those Swiss cheese are how well the organization focuses on safety, what kind of supervision you can see for yourself. But the idea is that there are should be multiple barriers that protect an event from harming a patient. And that, of course, it's what replaces the modern blame game. It's to try to understand what happened in these various barriers that allowed something to happen. So when you talk about why things go wrong in a hospital or a doctor's office or any kind of healthcare environment, there's a lot of different aspects here. Maybe management doesn't care. In fact, maybe they don't want to hear about an error. And they don't care if it's never reported, because it's going to make them look bad. Maybe your work environment is such that you've just worked a nurse 16 hours and have not provided her adequate support. Maybe we got a team down in the OR that can't stand one another and has a poor role model in a surgeon just creating the environment for a mistake. Maybe we have 5 A-plus performing team members, but number 6 is a C. Maybe we've simply asked somebody to do something that they've never been trained to do. Maybe the whole institution is just a problem. But all these things, and then sometimes the patient hasn't done something. You walk into a hospital and there's a patient's Bill of Rights in many hospitals. It says, what does a patient deserve from the organization? Well, there's also a set of patient obligations. When a patient comes into a hospital, they're supposed to tell the doctor what medications they're taking. They're supposed to tell the doctor other things about themselves. So there's a patient side of this responsibility too. What we want to avoid when something bad happens is saying, I know why it happened, that's the reason, close the case and move on. We always should resist the easy explanation, no matter how obvious it may appear. Okay, what's that first drug up there at the top? Anybody want to guess? Iserdil. Anybody else want to guess? Plendil. You're good. Well, Plendil, Iserdil, or Zestril? Well, $450,000 later in this particular case, a patient got the wrong drug, survived, was awarded $450,000, and when some person went back and examined the average number of steps from the doctor writing an order to the patient receiving the medication, they identified up to 50 to 100 steps took place, each one of them vulnerable to a mistake. That happens to 1 out of every 20 patients in our hospitals. They get an adverse drug event. Now, checklist, we'll talk about ways in which people have tried to avoid harm or to try to make it easy to hardwire safety. Now, this is an article out of the Annals of Medicine. It was written by Atul Gawande. Dr. Gawande is a Pulitzer Prize-winning Boston surgeon who is a prolific writer in healthcare. He's given the Harvard Medical School commencement address 2 out of the last 3 years. If you just want to have some great reading, look up Dr. Gawande. It's just fascinating. But he proposed, he said, you can't read this at the bottom, but it says, if a new drug were as effective at saving lives as Dr. Pronovost's checklist, there would be a nationwide marketing campaign urging doctors to use it. But we don't make use of checklists. I'm not saying we make a whole compendium of checklists to rule our life, but we should always use SMART checklist. Those of you who are pilots know that SMART checklists are a smart thing to do. So let's talk about a very common checklist. A checklist brought to us by the American Academy of Orthopedic Surgeons, who designed the universal protocol after that society said, you know, we can't tolerate these wrong site surgeries. This was not brought to you by the Joint Commission. This was brought to you by the doctors. But the Joint Commission adopted it and said, you know, we think it's kind of a right thing to do to make sure we're operating on the right patient, the right side, have the right hardware in room at the right time. You know, it doesn't seem like too much to ask. That was 2004. This checklist which applies to every procedural area, not just surgery, but to a blood transfusion, to a bronchoscopy. It's not just surgery. It is, in the surgical world, this has evolved by the World Health Organization into even a more comprehensive checklist. It's called the Surgical Safety Checklist. And no one is saying that you should use this list. They're just saying you should use something very much like it. Well, let's get back to culture. Now, no one would probably disagree that that checklist is not a bad idea. I know when I had my hernia repair, I was really hoping they'd operate on the correct side, especially since I'd already had one done on the other side. But I wouldn't have known how to prevent it, because if any of you all have ever had 1 or 2 milligrams of Versed, you know you can't do anything. So let's go back to 2006. Recall that universal protocol was mainstream in 2004. And there's an article in the Archives of Surgery called Incidents, Patterns, and Prevention of Wrong Site Surgery. And you read the little abstract, and this is taken directly from the abstract. Wrong site surgery is unacceptable, but exceedingly rare. And major injury from wrong site surgery is even rarer. Current site verification protocols could have prevented, you have to wonder about who is writing this, could have prevented only 2/3 of the examined cases. This is a study by a group of distinguished Boston academic surgeons. So this comes out on one day. On the next day, what do you think is the main editorial in USA Today? Staying alive. Whose side are they on? Not only is wrong site surgery happening, it's happening with an incredibly higher frequency. So this whole article says, what's wrong with those surgeons? What is it they don't get? That's the culture that many of our physicians grew up in. And of course, if you're working now in Boston, at Harvard System, there's a great 100-page book that you can download online. It talks about when things go wrong, because things go wrong so frequently, the issue is what do we do when they do go wrong? And I urge you to read it because it's just great stuff, because it tells patient stories. In fact, the non-medical literature is so full of this issue. This is the Atlantic Monthly. This is written by a CEO whose father comes into the hospital for a very minor condition and who dies of a pneumonia acquired in the hospital. This is the title. Is that really the culture of healthcare? So culture, what is culture? It's how we talk to one another, how well we work together, and how well the organization supports those two. And I like to use this example. I grew up when I was in medical school. Every Wednesday or Thursday night, I watched Cheers. I can't remember if Cheers was one night and MASH was the other night, and that's what we always watched. And, you know, group of people, whether the guy was a postman or a bartender or a barmaid or whatever, they all gathered together. They had a lot of fun. They trusted each other. They could share everything with one another, and the tune went where everybody knows your name. They're always glad you came. You want to be where you can see our troubles are all the same. You want to go where everybody knows your name. In healthcare, that's where I want to be operated on, in an environment, in an operating room where everybody's talking to one another and knows what the other person's doing or not doing. Did you know that when an airplane crashes, in 74% of those events, the pilot and the co-pilot, that was the first time they were ever paired together. So when you walk on a plane, and if you're really paranoid about plane crashes, which you shouldn't be paranoid about plane crashes, as you walk to the right, ask the two guys to the left how many times they've flown together. So, sentinel events, we've talked about those. It's not equipment. It's how we talk to one another and how we demonstrate leadership. This is why bad things happen. It's not the oximeter. It's not the medications. It's not how well the surgeon did the operation. It's these other things. Now, this is a classic study that takes an ICU, two people who have been working together for years, an ICU nurse and a doctor, and it asks the RN, how well does that doctor communicate to you? And the RN says, you know, I'd rank him about a 45. So they ask the same doctor, how well do you communicate with that nurse? And he says, oh, man, it's about 90%. I'm really satisfied. But what we're seeing is a different reflection of the two cultures. A doctor measures effective communication by how well someone follows his order. A nurse measures effectiveness of communication as how well the doctor listens to me. That was the genesis of what we call the S-bar tool, a template that allows doctors and nurses to talk together to exchange essential information. Doctors want bullet points. They don't want a story. That happens, again, every day. In my world, an anesthesiologist, this is the same study. They go into an operating room and they say, how well do you work with that staff surgeon, the attending, the captain of the ship? Well, if you're a surgery resident with that surgeon, you'll say, oh, he's great. If you're another surgeon, you'll say, he's great. If you're an anesthesiologist, it sort of drops off pretty quick. If you're brand new to the environment and you're a resident, you're so scared to talk to that surgeon, you're going to say the communication is pretty poor. This should be alarming to everybody that works in an operating room. I tell this story about, imagine if you're in an operating room, busy hospital, academic, or community, and one day the surgeon walks into the operating room, a neurosurgeon, he says, hey team, how are you doing this morning? Dr. Mark, don't call me Dr. Williams, call me Dr. Mark, my first name. I want y'all to know today that we're doing some important stuff today. And, oh, I don't know you. You're new in the operating room. My name's Dr. Mark. What's your name? I want to know your first name. In fact, I want to know everybody that works in the. And I want to tell you that each one of you, if you see a problem, please tell me, because we're all a team. When I say that in front of people who work in operating rooms, they all laugh. because they can't imagine that environment. And it doesn't cost the doctor a thing. And that doctor has just earned the respect in a better and safer environment. And most of what we can do to accomplish this is pretty easy. And we know that when we have a great culture, this has actually been measured, we have fewer wrong-site surgeries, fewer infections, fewer decubiti, less post-op sepsis, fewer bleeding episodes, better employee retention, less physician and nurse burnout, a whole lot of better things. I use an example of culture and teamwork from long ago. In 1913, if you were perusing a British newspaper in London, you would have seen this ad. Men wanted for hazardous journeys, small wages, bitter cold, da-da-da-da-da, safe return, doubtful, honor and recognition in case of success. Anybody know what that ad was for in 1913 in London? It was put out by Sir Ernest Shackleton as he was planning his third polar journey to the Antarctica. And on that journey, the HMS Endurance, his British ship, was trapped between ice and eventually crushed. And his men survived on that ice floe for 19 months and were rescued after Sir Ernest Shackleton got in a small boat, traveled 800 miles across the open ocean, and came back. And when the men were asked what kind of culture, they didn't say culture, but they said what kind of attitude, which is part of culture, did Ernest Shackleton demonstrate during that time, he basically said, it was simply he was wonderfully irrepressible considering the heartbreaking reverses. In other words, this guy was always upbeat no matter how difficult it became. When we have a culture of safety, if I was starting a hospital or I was a new guy at the hospital and I say, I want a culture of safety. I put out a memo, I want a culture of safety tomorrow. That would not be effective. In fact, my daughter's a nurse, and she says, Dad, they send out memos and they never tell you what in the world the memo is for. They just say, do it. But what you have to have, if you want a culture of safety, you have to teach your people about safety. This teaching part, I kind of liken to you're a young couple. You have a nice new home, and you've decorated the home. You have a stairwell up to a living room. You have a nice table with a sharp corner. You have drawers that open. You have nice cutlery. Then you have a baby. And all of a sudden, your vision of your environment completely changes. That's what we want to develop when we talk about a culture of safety, is that collective mindfulness of how someone can be harmed by your environment. All of a sudden, your perspective becomes different. So we need to teach people about the science of safety. We have to be flexible when things don't go well. We have to share and report. We have to keep people informed about what's not going well. And we have to have a just culture. And I want to really spend a few minutes talking about just culture because it's very important. And when we have all those things, we then have a culture of safety. There are tools to measure the culture of safety. The AHRQ, each year we do an annual safety survey for our hospital, as do 2,000 other hospitals. And the one question on that culture of safety survey that would tell me how safe the hospital is one question that they ask everybody, and they ask all employees, would you have you or your loved one treated in this hospital? And if those employees can't say yes, I don't want to be treated there. So if there was one single measure of a hospital that I didn't know about that would prompt my selection, it would be that question. Now, at North Mississippi, we've made some great efforts in terms of reporting. But 5 years ago, when we first started doing our culture of safety survey, there's also a question on the survey that says to a line worker, if you report an error, how likely are you to be punished? And to our extreme disappointment, we found that 80% of our line workers, our clinical caregivers, were saying, I'm fearful that if I report an error, I'll be punished. So what's the likelihood of anybody reporting an error? 0. What kind of culture do you think that sets up? Not good. But we've made great improvements. We now have a very elaborate process in place, very public, to say, let's share. You're not going to be punished. In fact, we now have a safety hero system that helps us know, helps us encourage employees to tell us what they see. And of course, a just culture is saying, well, if we're always going to be so soft on an employee for reporting an error, maybe an error that they caused, how are we ever going to get to any degree of accountability with that employee? Are we just going to sort of say, oh, don't worry about it? We're going to get them a slap on the hand, or we're going to fire them? That's the challenge in a just culture, is avoiding the blame issue and the accountability issue. So I'm going to share a couple of examples that maybe helps illustrate this. Now, these two individuals here, Carl Dorsey is a radiology technician who today works for Virginia Mason, has worked for Virginia Mason for a long time. Virginia Mason Healthcare up in Seattle. Gary Kaplan, our speaker from last year's meeting, is the CEO of Virginia Mason. Miss Mary McClinton, a social activist in the Seattle area, devoted mother. She comes into the hospital. She is actually, her physician is the chief of medicine at that Seattle hospital, at Virginia Mason. So she's really doing okay. She's had a syncopal episode, and they're just doing some arteriographic studies. And Carl Dorsey is the radiology technician in that radiographic suite. And Carl, for years, has been used to putting the betadine out, saline out, and the contrast media out. He's done it for years. Well, one day, betadine's gone. They've gone to a new antiseptic called chlorhexidine. So chlorhexidine, was it contrast or saline was next? That's how it's lined up. And there's no dispute about any of this. Well, 2 weeks after that arteriographic study, of course, she dies. Patient injected with toxic antiseptic instead of X-ray dye. So how did that organization respond to that? They didn't know what happened to start with, because she simply went into multi-system failure, and it took a while for them to figure it out. But when they figured it out, they told the family and they told the paper they made a mistake. And today, when you walk into Virginia Mason, into the lobby, there's a picture of Mary, and it says, "We killed Miss McClinton." They made it very visible. And in fact, they were so devoted to making sure it didn't happen again, they created a whole new safety award named after her. And they said, we want all of our employees to talk about errors, to share them, and our goal is to prevent all harm. So what's happened to Virginia Mason since that Sentinel event? Fewer injuries and deaths, sense of pride and satisfaction's gone up. Their malpractice insurance costs have dropped. They have more business and they have greater trust. Who recalls the headlines in the last year that Lowe's and Walmart are now sending all hips, knees, spines, elective cardiac services, and transplants to one of 4 hospitals, and one of those is Virginia Mason? Does it tell you why? Because they trust the organization. And by the way, this is one of the lowest cost providers in the Seattle area. And in 2009, they won the preeminent national award for patient safety. They weren't going after the award. They were going after becoming the safest hospital in the United States. And going back to the original incident, which was so easily preventable, as doctors will say and nurses will say, why am I being asked to label a syringe or a bowl? That's the reason. How did the manufacturer of chlorhexidine say, gosh, I can't have this happen again? They simply made it impossible for chlorhexidine to be injected. They put it in a different delivery form. They designed the system to prevent an honest error from harming the patient. So Virginia Mason was kind of like maybe our hospital at one point in time. Virginia Mason was asking employees to report patient safety alerts, kind of like our good catch. Well, in 2002, the program started, and there's a few reports. 2004 was the incident. And when Virginia Mason held out to all of its employees, we're going to be honest, we're going to admit our mistake, the patient safety alerts, those events reported by employees of potential harm, went out the roof. It was like, we trust this organization now so that we can report possible errors. And these were some of the errors that they talked about. The newspaper called this the bow wave of a seismic change in American medicine. They immediately admitted their mistake, came together, da-da-da-da-da. But at the end of the day, it helped restore trust in Virginia Mason. And as physicians, this was all driven by physician leadership. And physician leadership is so powerful. So that was a clear demonstration of a fair and just culture. That systems should be designed so that reliability and human reliability and humans should be designed knowing that none of those will ever be perfect. So have you ever thought about how we respond if something goes wrong? So let's say you're in two operating rooms side by side, and neither team really cares about the universal protocol. In fact, there's someone assigned in the room to read off the protocol so that they can check the box, but no one really pays attention. The surgeon really doesn't care. He considers it a nuisance. Well, one day, both teams, neither one of them follows the universal protocol. Neither team cares, but by bad luck, something bad happens in one of the operating rooms. Well, that team might be punished, right? This team would never get any punishment. But they both did the same thing. It was just that our punishment was based on the outcome, not what they did. And that's part of, again, how we respond to an error. We usually don't respond if no injury results. The just culture approach says we got to look at what the people did, not what happened. So we talked about when do we not blame a person to when do we really hold someone accountable. And there's sort of three areas here. Someone just had a mental slip. And I know about that. That's happened to me more and more. So I have great appreciation when I forget to do something, I forgot a step. That, should I be fired for that? Hope not. Maybe my barcoding system that the hospital told me to use for every medication wasn't working that day because the computers were down, so I did a workaround so that patient could get the medicines on time. That was risky, but I needed the patient to get their medications, but I didn't follow hospital policy. I took a shortcut. Or maybe I said, I don't care about this. I don't really care about my job or the patient. I just gave them the medicine. Well, if you start to think in this way, this person you're going to support, this person you're going to coach, this person you're either going to discipline or get them off your team. And that's sort of what we're talking about, a just culture. And that even applies a little bit to our family lives. American Airlines, we're not just talking about health care. American Airlines has fully embraced the just culture because they want to know when something's not working in their airplanes. And they want to know when something's not working well on the manufacturing line. So we've already talked about this a little bit. We'll talk about a different example now. Still on just culture. This is a few years later in Seattle. Recall the Virginia Mason case made national headlines, right? Kim Hyatt. This is a picture of Kim in high school. Kim has always wanted to be a nurse. She loves to ride horses. She plays the piano. Both of her parents are physicians. This is her 20-some-odd years later. She's achieved her dream. She's been a NICU nurse now for 20 years. She absolutely loves her job. She's been written up by pediatricians as one of the finest nurses around. She works at Seattle Children's. This is baby Zau, Z-A-U, She was born prematurely, and she's being cared by Kim in the hospital for most of the 8 weeks that she's been there. How did I hear about this story? I saw this headline. She has 2 daughters, and she's found hung in her closet. And I read the story, and it says she killed herself after overdosing a baby, revealing the anguish of caregivers who make mistakes. So there was a miscalculation of the amount of magnesium in an IV fluid. And you can imagine a tiny baby like this. I think all of us can imagine how that could happen. So how did the hospital respond when this was discovered? They escorted her out of the building, took away her license. She couldn't get a job for years. The Seattle Nurses Association came to her defense, but she eventually killed herself because she could never get the job she wanted. In fact, the Washington State Nurses Association took this so seriously that they began to ask every hospital that they work in, does your organization support reporting errors? They named the Nightingale Award after her, Kim Hyatt. And an anesthesiologist writing in the paper, not long after that, the fact that the hospital changed its policies after the death implies that they realized the policies were inadequate. Despite this, the hospital decided to fire the nurse for an arithmetic error. If we fire every person in medicine who makes an error, we will soon have no providers. It is my belief that if the nurse had been dealt with appropriately, with compassion and insight, that she today would be a valuable and happy nurse. These are our huge opportunities in healthcare. Where were physicians? I don't know where physicians were in any of this, but where were the doctors? Maybe they were her greatest defenders, maybe not. But you always have to ask yourself, what was the doctor's role here? So we saw in this last case that there was a patient who suffered because of this medical mistake. There was also caregivers who suffered. There's multiple victims when bad things happen. And of course, the organization, what do you think happened to Seattle Children's reputation? I mean, the Nurses Association was all out and against this organization. It's probably taken them a decade to recover from this incident. Switching gears, industries a little bit. If you were looking through a high-end magazine a few years back, you would have seen this ad from KLM. At that time, KLM and British Airways, considered the finest international airways in the world, safe, comfortable. And the ad was, fly with the best, people who made punctuality possible. And here's a distinguished-looking captain here. Of course, KLM is a Dutch airway. Now, fast forward, you're now on a runway in the Canary Islands. There's fog on the runway. There's the KLM plane at one point on the runway, and there's a Pan Am plane at some other point on the runway. Both of them are 747s. The Pan Am 747 is actually famous because it was the first 747 to cross the Atlantic. The KLM 747 is considered the queen of the KLM fleet. The Pan Am co-pilot says maybe he counts these as 3. And he's referring to the tower, describing, was it the 3rd or 4th exit off the runway that we're supposed to take? The KLM says, we're now ready for takeoff, and we're waiting for ATC clearance. The tower tells KLM, you are cleared to pop a beacon, climb, and maintain after takeoff. KLM, all roger, sir, we're cleared. We're now at takeoff. The KLM captain, he's in a hurry. KLM is known for punctuality. You saw it in the ad. They're behind times. The fog has slowed them down. We're going. In fact, he's so agitated, he's reverted to his native language of Dutch. Can't really understand that very well. The tower says, okay, because they didn't really understand it either. The Pan Am co-pilot is listening to this and is a little confused. The tower says, stand by for takeoff, I will call you. The Pan Am co-pilot's getting a little nervous because there's only one runway. He says, we're still taxiing down the runway. But there's some noise. Something happens where they can't hear the transmissions very well. No one. The tower says, Roger, Alpha 1736, runway clear. Pan Am says, we'll report when we're clear. Tower says, thank you. The KLM flight engineer is so nervous, the third person in the cockpit says he's so nervous about knowing where the planes are, he's gone full to Dutch, his native language. Is he not clear then? The KLM pilot says, what do you say? No real good response. Make a long story short, KLM pilot says, we're going. The next thing you know, the Pan Am pilot sees the landing lights of the KLM Boeing 700 meters away, full speed, taking off. The last thing on the black box recorder is a scream from the captain. That's the computer animation of the two 747s collided. The Pan Am desperately trying to get off the runway. The KLM trying to take off too quickly. The aftermath remains today the worst aviation disaster in history, with 583 people died. And of course, there's a great PBS or Nova special on this. This is just such a classic story. It's when crew resource management really took off in the aviation industry. And that's what I'd like to talk to you a little bit about, crew resource management. Incidentally, KLM says, oh my gosh, we just had a terrible crash. Call up our test pilot. Call up the guy that's in our ads. He's our chief instructor. Call him up. We need him for PR work. Where was he? He was dead. He was the pilot. That guy. So what happened? A lot of different factors came together. At the end of the day, communication and leadership. A lot of other examples. United Flight 173, perfectly beautiful 707, a DC-8, 4 engines, landing in Portland. Front landing gear light doesn't come on right. Back then, there were 2 pilot, co-pilot, engineer. The co-pilot and engineer watched the fuel tanks go dry. But the pilots intimidated them so bad they're afraid to tell him. They literally run out of fuel miles away from the airport, crash and kill 10 people because the pilot, the co-pilot and flight engineer were afraid to tell something to the pilot. Real case out of the malpractice annals in the southern United States. 45-year-old woman wants to spend more time skiing. She's scheduled for orthopedic surgery Friday afternoon, big academic medical center. Surgeon is the chief of orthopedics. The OR is running late. The nurses are upset because some of them got to get home and pick up their kids. 2 nurses have been moved to ortho to do a no-brainer case. It doesn't really matter that they never worked in orthopedics because this is such a simple case. There's repeated interruptions or calls to the chief of orthopedics. The team is interrupted by an anesthesiologist whose machine has run out of EKG reporting paper. He wants circulator to go out and get him some. No one really knows each other in the room. The surgeon is asked is playing loud music in the room, and he asks for a syringe with epi to put into the joint space of the knee. So there we are, Friday afternoon, running late, understaffed, nurse not familiar, surgeon doesn't introduce himself, pressure to complete the case. Team's interrupted. The surgeon has requested an irrigation solution with epinephrine. There's no verbal readback or confirmation of syringe contents, no labeling. Healthy young woman given 20 cc's of 1 to 1,000 epinephrine in her knee suffers severe MI, permanent visual impairment from a simple no-brainer case. This is not so long ago. I'm going to skip some of this. So we go back to, we had asked the question before with Ascension Health. We talked about Ascension Health saying our goal is to eliminate all avoidable harm and deaths, and they're going to take all these steps. How well did they do? Well, they didn't get there. But starting in 2005 and ending in 2009, they almost got there. That's a lot of lives saved. So even though they may have set the goal too high, it was the only goal to set. And during this time, in which there was an 80% national increase in pressure ulcers, Ascension Health, when I was there, they said, you know, we're going to spend $90 million and buy special beds and mattresses to prevent pressure ulcers. And because of not only that, but good nursing care, during the time in which there was an 80% increase, they had a 95% reduction. Pretty amazing. My daughter, I'm going to reference my daughter one more time here. She was an ICU nurse down at South Alabama, and she's heard about all these safety initiatives for a long time, and I like to think that she's extremely conscientious. And we were talking about this central line associated bloodstream infection deal. And of course, what that involves to a nurse, it says, you know, when you're helping a doctor put in a central line, just do some simple stuff. Prep the area with chlorhexidine, let it dry, drape it, wear a gown and gloves, put a hat on, and wear a mask. Not rocket science. And it's not nebulous science. It's known science. It's known that if you do these things, you just about eliminate bloodstream infections from central lines. She says when she first got this protocol, it was in the form of an email from her nurse supervisor. And it basically said, so the first thing she knows about this is the what. The what is all nurses in the ICU are to make sure this checklist is followed. There's no whys, there's no hows, there's no discussion as to what the responsibility of the doctor is. But that nurse is supposed to make sure that it happens. You tell the surgeons that they must do this, and you report them if they don't. But as she's told me, she said, Dad, I kind of understood this, but there's no one that actually told us why we were doing these things. So one morning she calls me at 7:15. She would call me. She worked night shift. She'd call me, and she said, let me tell you what happened last night. So I'm helping the chief of trauma surgery at the University of South Alabama put in a central line. And he doesn't have a mask or a hat on. And Jessica says, Dr. So-and-so, am I going to be able to check the box that says you wore a mask and a hat? He says, Jessica, you're really trying my patience tonight. And again, it's kind of like, that may be a small incident, but that colors that whole culture. Because the nurse that saw that in the next bed, well, I'm not going to even ask him next time. And it was very simple for that doctor to have simply been accountable. Which raises a question that maybe doctors should start asking themselves is, when I was putting in central lines and I was faculty at UAB in anesthesia, that was in the world when every patient somehow had an indication for a PA catheter and a central line. We were putting it in everybody. History of hypertension, get a PA catheter. A little heart failure, get a PA catheter. Sometimes we do them under the drape. Sometimes we do them with a flashlight. At some point during that time, I wasn't aware that I was exposing the patient to a deadly bloodstream infection. But at some point in my professional career, I did become aware. At that point, if I didn't follow the protocol, why would I have been allowed to continue to practice by exposing a patient to a potentially deadly complication? Why would not a peer have spoken up? Does that ever really happen in our world? Not often. But that's where physicians need to step up for accountability and leadership. This is a story that actually came up a couple weeks ago. This is Dr. Reinertson came and spoke at our organization. He's a safety expert, and he gave this case. 42-year-old man arrives in the ER on April 24th, 2010. He's got difficulty walking, rule out epidural abscess, so he comes in the ER at 2 o'clock, and MRI is ordered at 3 o'clock, sent to radiology at noon, MRI completed at 4:30, MRI interpreted at 7:30. Patient at that point has quadriparesis, needs emergency surgery, and he spends 23 days in the hospital, 6 weeks in nursing home, eventually goes home in a wheelchair. How would your organization interpret that? Is this just, hey, I got a log-jammed ER, or radiologists are busy? Any guesses? I mean, what if this was you? It was on a Saturday. We don't staff up on the weekends. But clearly this patient suffered a devastating consequence because we really didn't appear to be that interested in treating the admitting diagnosis. The internal hospital in that case determined that this was not a serious safety event. It was just the way the situation of the conditions were set in place on that Saturday. So if you were looking at this hospital, you'd say, well, does this ever happen here? How often? How severe? How would you classify this event? You need to ask all these questions, because these are the questions that people outside of healthcare, the people who are paying our bills, are asking healthcare now. Leaders, Paul O'Neill came and spoke to our organization 2 years ago. Paul O'Neill was the CEO of Alcoa. He was famous for introducing safety improvements in a very hazardous industry. Leaders are responsible for everything in an organization, especially what goes wrong. So how do we change people? If everybody in this room was totally committed to what we were talking about today, how would you go back to your offices and your hospitals and say, how do I change this environment? Do I go antagonize my peers? Do I lecture to the nurses and the doctors? Do I tell administration to crack down on everybody? Well, one way we've done it at our organization is we now put a face to harm. This is a young lady, and we had her come speak to a conference just like this. She's a pharmacist. She's the daughter of our former chief of pharmacy who worked for our organization for 25 years. She drives a Mazda Miata, or she did. That Mazda Miata one afternoon had an interaction with an 18-wheeler. Fortunately, all she suffered was a calcaneal fracture. And she went to the operating room. It was done electively, placed in the prone position, brought back to the recovery room. She got nauseated. The nurse went to the Pyxis machine, we think, and drew up Finnegan, because the Pyxis machine showed Finnegan had been taken out. And the next thing we knew was that that young lady just waking up is screaming because her arm is just terribly painful. Well, the arm, which she was screaming about, had an arterial line in it. The IV line was over here. Why did she have an arterial line, 26-year-old healthy young lady, post-op recovery from a calcaneal fracture? It's because at that time, the surgeon liked to use this plasma gel approach to repairing a calcaneal fracture, and you got to draw arterial blood. Why did she still have the arterial line in the recovery room? Because we don't normally expect a 26-year-old having a calcaneal fracture in the recovery room to have an arterial line. It's because the OR team was very eager to get the next case in the room, and they didn't want to take time to remove the arterial line, which could just as easily be removed in the recovery room. Make a long story short, our organization spent a couple hours trying to figure out who to blame. While the father, and by the way, her brother, is one of our family practice physicians, says, I think this is a pretty devastating injury. I just went on the web and read about a Supreme Court case when a young lady violinist lost her arm from an intra-arterial injection of Finnegan. And sure enough, it's a black box warning. But we wasted time by trying to figure out who to blame. Finally figured out we needed to focus on the patient. And thankfully, because of a lot of good vascular surgeons and plastic surgeons, she basically ended up with this permanent sequelae of this injury. The radial circulation is completely gone. She still has some ulnar circulation. She'll forever have some sort of Raynaud's phenomenon in that arm. But I could have told this story as incident number 202, medication adverse effect, but instead, when she's up at the podium saying, look at this, and let me tell you how it happened, all of a sudden it takes on a different meaning. We didn't handle that well. Her father left our organization, and I think her brother was keenly disappointed. Victim, victim, victim. We are doing much better. So this is my last slide. And when we're talking about accountability and physician leadership, maybe we're talking about how to put in a central line. Maybe we're just talking about washing our hands when we walk in and out of a patient's room. But if we as physicians are going to get trust back with our patients and those patients' families, we have to step up to our leadership call and advance safety. And it ain't hard. It's a wonderful opportunity for us because all the nurses and everybody in the hospital always look to see what does the physician do. And the physician doesn't have to spend more money. They don't have to waste more time. They don't have to lose anything. They just step up to the plate. Better patient care, satisfaction, respect. Pretty easy. So, in the last words of Dr. Gwande again, trust in medicine, a journey to be and do better. Thank you very much for spending the time. We're going to have a question and answer session here. And thank you. Randy's got a mic if anybody likes to ask questions so everybody can hear it. All right. So we're going to go out there and do better? Well, yes, sir.
Some of the organizational and step procedures that you're talking about, some of the problems you're mentioning, I wonder, and I know a large degree of it is gender related. Mm-hmm. Men are from Mars, women are from Venus, and that's one thing I wanted you to comment on. The other thing I wanted you to comment on is the effects, hopefully a positive effect, particularly in prescription dosing of electronic health records, and also the pitfalls of voice recognition.
I hope I'll capture what you're looking for here. Let me talk to the first thing about the gender issue. So most of our nurses are female, and about 60% of our new doctors are male. That's changing quickly. But I guess I have found that an organization that goes to great lengths to support nurses when it comes to unproductive encounters with physicians, they win a lot with their nurses. When a nurse thinks that they can come to somebody in the organization, a leader, and say, I have a problem with a doctor. Maybe it's my problem, maybe it's his problem, but I'm concerned. If that organization responds in a positive way, that spreads through the organization is that this organization has a culture of facilitating productive communication. Conversely, if you don't do that, it works the exact same way. The organization, the nurses will say, don't bother. So we've implemented a number of strategies when for example, a nurse is put on the spot in a hallway by a doctor who may be complaining in front of staff, family. We've asked another nurse or a person to come up and stand right beside them. They're going to be their wing person. It's very hard to talk down to two people now. And all of a sudden you have somebody who is supporting them and listening to them and can back them up. We have some physicians in our organization who are outstanding role models. I mean, I can't tell you some of these doctors who have stepped up, and I could labor for 3 years pushing a safety initiative in my role as an administrator doctor, and I could not accomplish as much as, for example, I got Dr. Mark Craig, private surgeon, plastic surgeon, great practice on the outside. Why does he care about hospitals? But he does. One day he's chief of surgery, and he says, Mark, why in the world are we struggling with this universal protocol deal? Tomorrow, I am saying that no surgeon goes ahead with the case, no nurse hands the scalpel to that surgeon until we do a timeout. And it's like, when it came from a respected peer, someone who was convinced of what they should do, at some point we stop trying to persuade people, and we simply say, that's the way we do it here. But it has to come from a respected internal physician leader. And so in terms of the prescribing piece, we've gone through a very challenging time with the electronic health record. The e-prescribing piece clearly is an opportunity to reduce medication errors. I think when you get to the end of the electronic health record journey, when it's fully in place and people understand it, it's much safer. I'll have to say that during this implementation phase, you almost have to have a heightened vigilance because some of your safety risks are actually going up. So I don't have a good answer to that. It's just you got to be very careful about that. And so I hope I answered your question a little bit. Okay. Well, yes, sir.
Just an anecdote to that effect. Our hospital system uses an EMR. I'm a psychiatrist. Haloperidol is an antipsychotic that's used IM or IV for agitation. Haloperidol decanoate is used for long-term depot treatment of psychosis. It's in an oily, viscous vehicle. Twice we've had near misses where residents who are hurried ordered haldol decanoate IV for a patient, which had the possibility of causing essentially a fat embolus. So what our Pharmacy and Therapeutics Committee did in combination with our department is we made it impossible to order that through the formula, through the EMR. You have to call the pharmacist and order it.
Well, you know, there's even in our modern EMR world, you find these workarounds, and we've had to do quite a bit of those sorts of things in terms of risky medications. So, again, at the end of the day, the EMR is, at some point will be a valuable safety tool, but we're not there yet. I'll say one other thing we do. We talked about this young lady sharing her harm that she incurred in her arm from the Finnegan. At our board meetings now, at both our system board and our hospital board, it used to be that our quality and safety report was tucked down at the end of advanced reports to review if you wish. Now the quality and safety report is the very first item on the agenda, and it is discussed. We want to show the importance of quality and safety. We also want to let the board know that they're responsible for the quality and safety in that organization. You know, these things, again, are raising the visibility. Each quarter, we will now give them a pie chart, and it will show how many people during that quarter were harmed in our organization. Give you an idea. Last year, in a hospital with 500 beds, we had 232 instances of avoidable harm. That sounds like a lot. But the year before that, we had 270. And the year before that, we had 400. I had mentioned our success with pressure ulcers. You can't prevent pressure ulcers, especially in patients who are in the ICU. My gosh, they got tubes all over. They got tubes from ventilators hanging around them. They got oxygen on them. They can't move themselves. Some of them are even paralyzed. How in the world are you going to prevent a pressure ulcer? Well, I got a young physician, Dr. Lee Greer, who I'll put up against anybody in terms of his passion for quality and safety. And so we introduced what we call the CUSP concept in our ICUs. CUSP is a model that we've imported from Johns Hopkins, and CUSP, C-U-S-P, stands for Comprehensive Unit-Based Safety Program. And what we do is we go into a unit and we educate the nurses and the staff on the science of safety. And when they understand the science of safety, we then ask the nursing staff, we don't tell them, we ask them, from your perspective, knowing what you know now, what are 2 things that you think exposes your next patient to harm? Again, it's not a directive from up top, it's from the people on the clinical front end. And they tell us, well, our responsibility as administrators and physician leaders is to say, now that you've told us, we've got to supply the resources that you've asked for to make sure it doesn't happen again, and we're going to measure how effective we are, and we're going to keep making the improvement until we eliminate that risk, and then at that point, you identify the next 2. And it's a self-sustaining program from the troops up front, and I, as an administrator, sponsor a unit, and I'm required to support that unit who also has a physician champion to make those improvements. So let's go back to the pressure ulcer in the ICU. So this unit gets really fired up. So outside the unit where the patients and the families, where the families wait, is a big banner. And the pressure ulcers that are reported to Medicare are what we call stage 3 and stage 4 pressure ulcers, big pressure ulcers. But our goal was to eliminate all pressure ulcers. The pressure ulcer that results from the tiny oxygen cannula going in your nose or the oxygen tubing that goes over the top of your ear. Any skin breakdown. Well, 12 days without a pressure ulcer was the first sign. Went 12 days without a pressure ulcer in a very busy ICU. Darn, 12 days. That's not very good. Well, the next time it was 37 days. Well, that unit now, after 2 years, is up to 375 days without a single pressure ulcer in an ICU patient. And that's extraordinary. And it builds pride, and it builds teamwork, and it helps our patients. And one of our doctors, Dr. David Irwin, he didn't mind me using his name, he especially was effective in inspiring this passion among our employees. Because he said, I just admitted my mom, took her home, and we've been treating her pressure ulcer on her heel for 6 months, and she can't get up and get around. So when you're showing, again, the face of harm that potentially can affect all of us, it's a very powerful message. So.
The word I hear over and over is team. Even when it's not said, I keep hearing it from the slides. And I think that there's a time for interdisciplinary education like no other. It's a wave that is long overdue. And I think when people come together to learn, whether it's in simulation or whether it's at the bedside of a real patient, your mom or my mom or our child, we will learn to work together as a team. That's right. And it won't be holding a scalpel away from a surgeon. It'll be, don't we want to do this first?
Exactly. That's a very good point. Let me add one thing to that. You're so right. It's all about a team. When something goes wrong, the other challenge has been for physicians and health professionals is how and what do I tell a family about what went wrong? And am I going to create a liability risk? I can remember calling physicians when something went wrong, good doctors, I'm not saying where because it could be anywhere, and the first thing out of their mouths is, Mark, is our conversation discoverable? And unfortunately, we've had to grow up in that world, and it's tragic that that's the response. But that's getting better. Insurance companies, you all may be familiar with Pro Assurance out of Birmingham. Second largest medical malpractice company in the United States now. They saw what Ascension was doing. One of Ascension's objectives was to reduce perinatal injury and harm. So they said, okay, if we can get the team, the obstetrician and the labor and delivery nurses, to make sure we have a common language when it comes to interpreting the fetal heart rate tracing, if we can get the team to agree to communicate effectively with family, to give fully informed consent, to report everything that goes wrong. As a team, we will reduce your malpractice premiums by 10%. You will not have any deductible for that first incident. And, basically, we'll support you in all that. Because at the end of the day, what they found is that when you're honest with patients, they tend not to sue. And, or at least if they do sue, they're not sitting here angry after having to engage in an adversarial game. But the team part is so important, and there's a long way to go on that. But you're right.
And speaking of culture, it seems that we're at a time where those people at the very top of organizations are not willing to take ultimate responsibility. And it's not just the CEOs of our healthcare institutions. You can say government or business or politicians. Do you think it's possible to successfully work towards this culture change in a healthcare institution unless the CEO at the top really buys into it? His or her responsibility and his or her commitment to these changes in this culture?
Well, if the guy at the top doesn't buy in, it's clearly going to slow you down. and it's going to put you at greater risk. And I'll have to say, in different organizations, you can find a leader who advocates full disclosure and supports you, and one that says, oh my gosh, don't let him. I don't have the right answer for that. I will tell you that most leaders of major successful healthcare organizations are now physicians. And again, that's another opportunity for us. But I'm not saying there's a great answer for that. Sometimes you just have to keep pushing. But physicians, I'll go back, physicians have, especially if they can get together, a medical staff working together could probably overcome any administrative leader if they were effective. Okay, well, thank you all again, and enjoy the evening out here.
We have a Dragon system on our
Oh, I
computer.
forgot, I didn't